Hi guys, my name is Charles Kunz and I'm one of the surgeons at Southpaws. Today we are live streaming an L2-3 hemilaminectomy in a dog with a disc rupture. And if you look on the screen, you can see in the picture-in-picture on the corner the CT myelogram that we've done that shows where the disc rupture is. So in the middle of the CT scan, we can see a big bright white horizontal line, and that's the needle that I put into the dorsal spinous process of L3. And that's going to tell me where I have to go in. So, so the needle is in the dorsal spinous process of L3, which is sitting right here. And so again, that's going to tell us exactly where we need to go in. So as always, please subscribe to our channel. And if you know of anybody else that would be interested in watching this, please send them a link or let them know. Also, we have a new Southpaws Facebook group, which is intended to allow discussion about different topics related to surgery. We'll also be notifying you of our live streams, and we'll be doing some live stream webinars and all kinds of stuff. And people can also pose questions or comments that they have about surgical techniques and equipment and that kind of thing. So if you're interested, go to our community on YouTube, and there's a link to the Southpaws group. But if you can't get to it that way, then the Southpaws group, just go to facebook.com/groups and then do a search for Southpaws, and you'll be able to find our group. So we'd love to see you there. If you're in the veterinary industry, so vets and nurses are welcome to join up. There will be a question on the group when you go to sign up, and it'll ask you a question, and then depending on your response to the question, we'll approve or deny your request to join the group. So looking forward to seeing everybody there. As always, if you have any questions, the live chat is running as we speak, and I do have some nurses that are in here that'll monitor the chat. And so if there's anything, any questions that you might have, I'd be happy to answer them for you while I'm going. So I'm just trying to center the video image. Here we go. That's pretty good. I am happy with pneumatic. Size 3 Gelpies would be great. Can somebody please comment on the audio and just make sure that you guys can hear? Oh, this is a new laminectomy drill. I haven't used this one before. I'd like a 5 mil, please. Great. All righty. So yeah, you guys are in big trouble because I just attended a social media course in Sydney over the weekend, or on a Thursday. And so I have all kinds of new crazy ideas on things that we can do to get more engagement with referring vets and that kind of thing, and do a bit more education, which is what we are really, one of the things that we're really passionate about. So that should be a bit of fun. So I'm just getting all draped in here. So again, palpating the dorsal spinous process of L3 here. So that's L2 right there. So this is the site that we're going to be operating on. If I can have it, I would love it. Thank you. Just getting our bipolar out. Bipolar is really handy if you're doing spinal surgery because you don't get the twitching of the muscle, and also you're less likely to damage the spinal cord because you're not passing an electrical charge right through the right through the spinal cord when you cauterize. Thank you. So 5 millimeter burr. That sounds so nice and quiet. We have a brand new laminectomy drill, which is kind of exciting. I get excited about these kinds of things.
Would you like a needle and syringe?
Yes, please. And can we get a stool for Jess, please? Just so you can see right down there. Just a really low stool, if we could. Do you think you'll need a stool? You're not sure. What's that?
I roll my toes. Don't follow me.
All right, so getting started here. So there's my dorsal spinous process of L3. That's where my needle is. That's L2 right there. So I'm going to extend my incision from L4 over L3, L2, and L1, just so that I'm not cramped for space at all. And is the stool right up against the table? And we use a needle to identify where our spot is going to be. In human medicine, they'll have the fluoroscope unit right in the room with them, and they'll often, can I get the cautery plugged in, please? They'll often check just to make sure they're absolutely in the right spot. That's a really common cause of lawsuits in human medicine, is the neurosurgeon operating on the wrong site. So there's L3 again. Just get my Gelpy retractors in here. Do you want to try to lay out some of our instruments, please? So L3 and L2, and I will find myself, particularly if I don't put a needle in, I'll find myself checking, a half a dozen or a dozen times repeatedly during the surgery to make sure that I am operating on the site that I think I am. So then I'm just going to use my electrocautery to incise through the fascia adjacent to the dorsal spinous processes. Okay, and then once I get this far, I can go ahead and pull my needle out because I know that I'm not going to get lost again. So needle's coming out here. So down to the apexial musculature here. Now, if you look at the CT scan in the middle, particularly, you can see the big water disc material on the right-hand side that's displacing the spinal cord over to the left. So this is a pretty dramatic compression here. And we'll just get some suction going here. And then what I'm going to do, Jess, is we'll get our syringe full. Did we get an orange needle?
Yes, yeah.
Okay. So I'm just going to have you drip, drip, drip on the spine, on the burr, about a drop a second when I'm drilling, so not yet.
Yeah.
Just getting our bipolar going here. Might have bipolar turned up, please. Yep.
Charles, since you methadone now, would you like that IV or
Methadone. So sorry, is waking up a little bit, or
No,
just
it's
get?
just been 4 hours since his last dose.
And he's not on fentanyl. You can give it IV is fine.
Thank you.
So now we can see our articular facet sitting right here, and that's going to be the center of our laminectomy. And this one, the disc kind of tended to go a little bit farther caudal rather than cranial, so it's overlapping the body of L3 back here rather than being exactly centrally located. All right. Let's get one last scalpel in here to retract cranially and caudally. And that's pretty good exposure there. So, just get a little bit of flush, please, in there to start with. Yep. Great, thank you. All righty. And I'll just try to reposition a little bit so we can see a little better. All right, now what I'm going to do is I'm going to take a large rongeur. I'm just going to take the dorsal spine or the articular facet off right here, and that's going to give us our little bit of a head start when we go to start burring. Okay. And then as I start burring, we're just going to drip saline, about a drop a second onto the burr. And that's accomplishes two things. One, it keeps the burr from getting too hot. And then two, it keeps the burr from getting too gummed up. And the nice thing on this disc is that the disc is really lateralized. Can you flush for me, please? The disc is really lateralized, which means that, that's great, thank you. The disc is actually going to protect my spinal cord a little bit as I'm burring. Big flush for me, please. Thank you. So that's kind of the extent of my laminectomy. That's great, thanks. That's kind of the extent, the length of my laminectomy, and then I just need to go the rest of the way through into the spinal canal. And when I'm doing these, if I get to the point that I see some bruising in the spine, that's great, thank you, that I see some bruising. I don't know if you guys can see that, but there's definitely some bruising. It's a point of relief for me because I know I'm at the right site. Okay, so I can see right through into the spinal canal here. We're going to get a real treat in just a second because this is going to come rushing out. So if you watch closely, I'm going to start picking this away. Okay, so all that bruised, that dark purple blood is bruising and hematoma. I have to be a little bit careful with my nerve root in this location. In contrast to when you're doing a TL disc, the nerve root is not as important as it is here. This is actually a functional nerve root that supplies the back leg, so I'll have to be really careful with that. And you can see some disc material coming out here. Let me see if I can grab that with my Lampert rongeur. I've got a little tag of periosteum here. There's a nice big chunk of disc about to come out here. So there's a nice big chunk of disc material. I don't know if you guys could see it before I suctioned it out. So there's some disc there. It's all right up against the spinal cord. Nice big chunk of disc right there. And I can see some spinal cord already. I doubt that you guys can see it there. So there's spinal cord right there. Can you see that, Jess? The white. So that's non-compressed spinal cord sitting right there. And then we still got some disc sitting on top of it out here. So that's nerve root right down there. Getting a lot of disc material out here cranially. I think that the camera angle isn't allowing you to see that very well. I'm going to suction that out. So I just got a big chunk of disc material out there. And there's actually a bit more disc cranially than I would have expected from the scan. So that spinal cord sitting right there, and that's very nicely decompressed all the way up in there as well. All right, so I'm just going to burr a little bit more cranially. Hi, Chris. Thank you. All right, so now the spinal cord is completely decompressed. I don't know if you guys can see that clearly. Nerve root is sitting there. And now I'm just going to burr ventrally a little bit. Can I get a 3 mil burr? I'm just going to burr a little bit ventrally now to see if we can get to the disc space so that I can fenestrate. Because fenestration definitively helps prevent recurrence of disc rupture at the same site. And so we always try to fenestrate these guys. So I'm just taking out lamina ventrally down there. Thank you. Trying to find the disc space itself. And you don't need to burr now, but thank you. So our disc space is right up here. I don't know if you can see it given the camera angle. I'm just going to burr straight into the disc space. So I've burred into the disc space, and I'm just going to get my pick and try to remove any residual disc material that might still be in situ in the intervertebral disc space to try to prevent more from coming out in the future. So I'm going quite deep into that disc space. All right, so that's pretty much it. I've gotten all the disc material out. Spinal cord is completely decompressed. Just do a little sweep back here caudally to make sure I didn't miss any under the cord. Yeah.
We want to do hydrocephalus extracorporeal surgery. Next big question, is this dog's deep pain positive?
Yeah, so the question about clinical signs on this dog, deep pain is positive, which is good. It has loss of some motor function and was painful and ataxic, but deep pain sensation was intact, which makes the prognosis much, much better for this dog. Can I get some mepivacaine, please? So that's pretty much it, guys. And I'm just looking up, so from, let's see, 5 a.m. in Sweden. So the question is, can I walk through the CT myelography in this patient? So we've done a conventional CT scan using soft tissue and bone algorithms, and then we follow that up with myelogram, and the myelogram is injected at L5-6 injury in the subarachnoid space, and we inject 0.3 milliliters per kilogram into the subarachnoid space, and then repeat the scan, and then that's going to show us where we have spinal cord compression. So now I'm just removing my Gelpies, tuck the muscle in a little bit here. Now the other question that comes up sometimes is, do we ever do a fat graft over the spinal cord to prevent cicatrix or scar tissue formation over the spinal cord? And the answer to that is we used to, but we don't anymore. The reason why we don't is because it's been shown not only not to be helpful, but in fact, the fat can actually contribute to further spinal cord compression later on. So I've got my mepivacaine here, and I'm just injecting that into the muscle around the incision. And that's going to provide some really good quality pain relief in the perioperative period. It only lasts about 4 hours, but we find that if you block that whole pain cycle initially, that they're a lot more comfortable for the entire recovery. Jess, can I please get some 3.0 PDS? Thank you. Any other questions? High-speed bird really essential for this surgery, and do we have to worry about bleeding while in surgery? Do we require any hemostatic medication? So I wouldn't do one without a high-speed burr. I know that some people will try to do it with just rongeurs, but I would really struggle to be atraumatic or non-traumatic to the spinal cord without using a high-speed burr. There was a study that came out a long time ago where they used a hardware store Dremel drill instead of a $10,000 laminectomy drill, and they found that the results of the surgery were the same. And so if I were to try to do this on the cheap, I would be using a Dremel that's been ethylene oxide sterilized rather than trying to do it with rongeurs. Now with bleeding, I don't find bleeding to be a big problem. The only time we see an issue is when you get into the venous sinus, which is ventral to the spinal cord. And when that happens, you get annoying bleeding, but rarely do you get dangerous bleeding. And so we don't use any hemostatic medications on these guys. The place that you can see more dangerous bleeding would be in a ventral slot, where if you get the ventral sinus or vertebral sinus there, I have heard of dogs not dying or not surviving the surgery because of excessive bleeding. And look, I don't seem to have a lot of issue with bleeding on those guys. And one thing that you have to remember is that if you do start getting bleeding on a ventral slot, is stop the procedure, pack it off. Like if you're getting a lot of bleeding, pack it off with some gel foam and wake the dog up and come back the next day. because I'd much rather have a live dog that I've had to go back in on twice than one that doesn't survive the surgery. That would be my biggest point of advice when you're having bleeding. That happens, that goes along with a lot of other different types of surgery as well. Certainly if you have a bleeding abdomen, you can't, it's harder to pack it off, although I have done that in the past. But if you're doing a total ear canal ablation or something like that, and you're getting bleeding that you can't control and you're worried, just stop the procedure, pack it off, come back in the next day. In humans, they call it a second look procedure. And as veterinarians, we're really reluctant to go back and do a second look procedure. We think we have to accomplish everything on the first day. But again, if I got severe bleeding today while I was doing this surgery, especially in a dog that's not, a critical neurologic case that's lost deep pain or something, I'm much more likely to pack it off, come back the next day. In humans, they get a lot more like gunshot wounds and things like that. And the first thing they do often is when they open the abdomen, if they can't find the source of bleeding, they just pack the whole abdomen off with laparotomy sponges, and then, and try to arrest the bleeding that way. And if they can't find the source of the bleeding, they'll, sometimes they'll close them up and come back the next day. So. Okay.
Charles, another question.
Yep.
What are the post-operative care and meds you suggest after this surgery?
So post-operative care, we are going to do pain relief in the form of methadone, or you could use morphine or oxymorphone or something like that. You need a full agonist opioid. I like to use non-steroidal anti-inflammatories in these guys because I think the protection from or resolution of inflammation in the spinal cord and in the peri-operative site is going to be really helpful. If they're non-ambulatory, we're going to put in a urinary catheter, which is going to allow us to manage the urinary status much more effectively. And they're also not going to get soiled with urine. So that's an important part of our post-op. And we usually send them home the day after surgery. And I know some people in town like to keep them for 8 or 10 days or something after surgery. But I think that with the stimulation at home, if the owners can handle it, I'd much rather have them home, stimulated and more engaged. And I think that they're more likely to make a more rapid neurologic recovery. And I have discussed this with Michelle Monk, who's our go-to physiotherapist, animal physiotherapist, and she agrees that the ones that go home seem to recover more quickly than the ones that stay in hospital. And that may be a biased population, where the ones that are more severely affected may not be discharged. But even if I have a dog that's non-ambulatory that has to go home with the urinary catheter, as long as we're able to control the pain, I'm happy to send that dog home, as long as the owners are happy to have a dog with a urinary catheter in. And we don't see any issue with urinary tract infections. The owners that take these guys home are usually very dedicated and are going to keep really good hygiene and that kind of thing. So we don't have any problem with sending them home with those. I'm just going to start my intradermal suture pattern here, and then I'm going to have Chris, our intern, come over here and finish up the intradermal suture pattern while I do the post-op orders. And I call Pauline, who may be watching. Pauline, if you are watching, hello. Everything went really well. I'll be calling you in a few minutes. All right, I'll hand this over to Chris, and I'm going to go and man the chat for a couple of minutes If you guys have any questions, please post them now while I'm watching. And otherwise, we will see you later on. Now, we may have another surgery today to live stream, which will be a soft tissue sarcoma removal from an elbow on a dog, but I just need to see what surgery suite my nurses put me in. So there's a comment, wow, at our hospital, we wait until the UCATH is out before we send them home, usually 1 to 2 weeks. I always feel so bad with them being in hospital for so long. So I think that's a fairly common opinion. In my opinion, I would rather send them home. And again, I've probably operated on a couple of thousand spines, and I'm not aware of any major issue that we've had sending them home with the urinary catheter in. And we're happy to get them back every 24 hours, 48 hours or whatever, to monitor the urinary catheter. But yeah, I have no issue sending them straight home. Any other questions? And please comment on the use of mannitol post-operatively. So that's a good question, whether mannitol is indicated. And back in the 90s, early 90s, when I was doing my residency, people talked about doing mannitol to reduce swelling in these guys. But what they found is that it actually doesn't make any difference clinically. The reason, or the place that they got that recommendation was that, or the thought they would do that would be from laboratory animals that were in a experimental setting, but in clinically, we find that it actually doesn't make any difference. So I do use mannitol for brain surgery, particularly if there's evidence of brain swelling, but I don't use it in spinal cord surgery. And I have Adriano from Brazil, parabéns. Grande abraço, so Brasil. Grande abraço para você também. And so I'm going to go ahead and stop the audio, and we'll go ahead and stop the live stream because everybody that's watching, I'm sure, knows how to do an intradermal suture pattern, and hopefully we'll be able to log on, or we'll be able to stream another surgery later on. So thanks everybody for watching, and look forward to seeing you later on today.